Hi, everyone, and welcome to episode 113 of the Veterinary Behaviour Chat podcast. And we've got such a cool episode today because we are joined by the one and only Dr. Gemma Pearson, whose career I find so fascinating and so inspiring because she's really carved a niche out for herself in the field of equine behaviour medicine. So you'll have heard me talk lots and lots about cats and dogs. I think we had an episode of rabbits, but we haven't yet spoken about some of the other species. And horses obviously are certainly one of the species that are really close to my heart. And we don't really hear a lot about equine behavior medicine. And Gemma is certainly somebody who's really massively, like I say, carved out that niche and sort of taken on the challenge of bringing, I guess, equine behavior medicine to the profession, if you like. So Gemma, hi. Before I do your career intro, because it's such a long one, hello and welcome. So lovely to have you here with us.
Hey, thank you for having me.
So Gemma's a vet. She's the director of equine behavior at the Horse Trust. She's also a lecturer in equine behavior medicine at the University of Edinburgh. And one very, very cool fact is that she is the first species-specific RCVS specialist in veterinary behavior medicine, and that is for equine. She's also a fellow of the Royal College of Veterinary Surgeons, so she's FRCVS, and she's done some brilliant work with BEVA, so with the British Equine Veterinary Association, which I'm sure we'll speak about later. And her PhD thesis is also a super cool one, which is all about the stress that horses experience as a result of veterinary care and how we can positively influence the horse's experience whilst they're being cared for by us vets. So yeah, it's quite a mouthful. Is there anything I've missed or forgotten?
No, I don't think so, career-wise. No, otherwise you'll get me talking about football and Leeds United. So we'll maybe stick to equine behaviour.
Let's stick to equine behaviour. But yeah, I do know that you're also a big football fan. But I really would love to kind of take it back to the beginning. And I'd love to ask you, just also from a personal interest point of view, how did you get into equine behavior medicine? What was it? Was there like a special horse, a special case, or was it just that you saw that it was missing or lacking in the veterinary industry? How did you get into it?
Well, we have to go a lot of years back for that, really. And that's before I got into vet school. So I didn't get into vet school until my third attempt. So I always say to people, like, don't be disheartened. If you want to make something happen, you will make it happen. And in that 2-year interlude, I spent a bit of time working for a riding centre, and I was, it was a riding school, but they also had a lot of show jumpers. So I'd been mainly kind of exercising those on a morning for them and mucking out. And then I worked for an equine vet in Doncaster. And that was where I really started to spark an interest in behaviour. And I think I'd always had an interest in training horses. I had my own horses. But this was where I started to see the needle-shy horses and the ones that wouldn't load. And I mean, this is a far cry from where we're at now with behavioural medicine. But that was that initial spark. And then from that, of course, that was in the kind of early 2000s. So I then came across Monty Roberts. Mm-hmm. And thought, oh, this is really interesting and this makes a lot of sense. And then went, well, okay, that's fine for that context, but that doesn't really help me with a lot of other contexts. Then came across Pirelli and went and started doing exams and things in that. And that's where I learned about learning theory. I didn't know it was called learning theory at the time, but I think two of the things that Pirelli did really well was really good use of negative reinforcement, really good use of shaping behaviours, and trying to prioritise having a low level of arousal when working with horses. And I think it was there that I really honed a lot of skills. And then I came across the International Society for Recreation Science. So and that was when I started at vet school in my first year at vet school. So that was the kind of driver behind it. And it was interesting to go through vet school. Whereas on the one hand, I had all of this traditional teaching about physical restraint and, a little bit of the horse has to know your boss and, blaming the horse for things. And then on the other hand, I was doing some work with the International Society for Recreation Science and the two just didn't fit. So I think that's where I've driven things forward to make them fit together.
Yeah, which is so cool. So I also dabbled in Pirelli quite a bit, sort of when I was, in my 20s, 30s, 40s with horses. And you're right, they are two such very different worlds, kind of your sort of hard medicine type world. And then the other world that a lot of horse owners are actually exposed to, perhaps more than veterinary professionals or even vet students. And so then as you went through university and beyond that, how were you able to integrate those things into actually being a vet and working in the veterinary industry? And how were you able to sort of get your colleagues and horse owners on side, if you like, or how were you able to educate both within the profession and outside of the profession?
Yeah, I think that's a really good question, because I think I learned a lot through doing things wrong at that stage. And when we want to make a change, we often want to show people this amazing new world and how to do things well. But if we go about it the wrong way, we actually consolidate their initial thoughts and feelings, and we actually push people away from that. And there were certainly times, probably, pre and during vet school, when I'd be like, oh, look, I can show you this, and that's wrong. And actually what I learned was that those people just turned away and I didn't have an impact on them. So it was really, like I say, I was lucky. Before vet school, I worked for a vet that was really, really open. And I think if it wasn't for that, then it might have been different. And then when I graduated again, I worked for a vet called Nigel Hazelden in Yorkshire. And he'd known me as a student, and I'd talked through some of these things, when you're in the car driving between calls, and I was being more careful about how I wasn't saying, oh, you're wrong and I'm right, which I maybe would have done a bit more when I was younger. And we talked through some things, and he was really open for me starting to do some behaviour consults and to help him with tricky horses. And I remember there was one racehorse, I was in the back office, and he came in and he said, oh, this filly, I think she was a 3-year-old filly. He said, she's needle shy, can't get near her, come and show me what you do. And that was one of those, quite a lot of pressure. I felt that I was used to dealing with needle shy horses, but then for your boss, it was a very experienced and very good and very quiet and calm vet to say, show me now. And thankfully, within 30 seconds, she had settled and we injected her and she was absolutely fine. And I think I learned from that. And also, you may have seen one of the videos that's been in many of my presentations, which was an FEI level Arab cross mare. And she had injured people previously, and it had taken several strong men, 20 minutes to get an injection into her for sedation IM. And actually that video is 1 minute and 13 seconds long. And what I learned was it was showing people cases where they could see for themselves this rapid change in the horse's behaviour and the safety aspect of it, rather than telling them. Because if you just tell people, you can imagine, a young girl fresh out of vet school, they're very happy to pat you on the head and tell you to just go away and play with ponies. Whereas when they see a horse that they know is dangerous, being calm and compliant with what's being asked of it, that really got people on board.
I love that. There's nothing like actually presenting the evidence, right, and showing it. I think you're right. And it's all about kind of walking the walk and not just talking the talk. And I think that as well, in small animal medicine, you can give presentations, but like you say, when you've got those videos or you're actually in front of people and you're showing them, I think that's a very cool way of demonstrating some of those things.
Yeah, and we actually know from human behaviour change research that even vets and scientists presenting them with evidence doesn't change their mind anywhere near as strongly as giving a case example.
Yeah.
And I'm sure we all remember going to see lectures where you can't remember anything about liver disease in the horse, but you remember the one case and the treatment that they gave that case. So now I really try and make things really case-based if I can.
Yeah, no, I love that. And I learn best from cases 100%. Yeah, so I think you're right there. And so you worked in practice for a little while. How did you then get to Edinburgh? And what sort of took you into the behavior route there? Because I think you did a residency first, right? In equine medicine in general medicine?
It was a mixed rotating residency. So it was a bit strange. So I wanted to do a residency, and a position came up in the ambulatory practice at Edinburgh. And at the time I was going out with a farmer in the Scottish Borders. So I thought, well, in terms of maintaining a relationship during a residency, being close is going to be beneficial there. So I thought, well, I'll go for this position. And then if they get to know me, I might stand a better chance of getting them. And I wanted to do internal medicine at that point because behavioural medicine just was not a thing. Mm-hmm. So I went up, worked in the ambulatory practice again, showed the videos of the needle shy horses, was seeing all these behaviour cases. And it was actually, again, John Keane, who's an internal medicine specialist. He was head of the hospital, and he said, so I hear you want to do an internal medicine residency. And I'm like, yep, absolutely. And he said, and then what are you going to do at the end of that? And I'm going to do all my behaviour research. He said, I'm not sure you should do a residency in something that you then plan to, all your research to be focused somewhere else. And, all credit to him, he kind of said, well, maybe we can create a rotating residency. And it really has been the best thing for my career. I can't thank John enough for that, because I was allowed to run the behaviour clinic throughout my residency and build, my caseload and knowledge and skills there. I spent most of my time in internal medicine. So I did my certificate in advanced veterinary practice in internal medicine, but I spent a lot of time on orthopedics. And such a high percentage of my caseload has musculoskeletal pain, and a little bit of time in soft tissue and the other areas. And then all my research, so my MSc, was all based around that horse-vet interaction. Mm-hmm. And I think what I'd say about my residency is it taught me what I didn't know, which you don't necessarily understand when you're in, maybe it's a bit arrogant to say that, but certainly when I was in ambulatory practice, I wasn't aware of what I didn't know at that point. Mm-hmm. And I think doing the residency has made me realise that, yeah, I can specialise in behavioural medicine, but when there is a musculoskeletal problem, as you know, they're often subtle ones. They're not a really obvious lameness. So you have to go to people that specialise in that and get input from that. And it was that whole team approach that has worked really well for me.
Yeah. No, that sounds brilliant. So let's dive a little bit into the types of cases that you would see in your behaviour practice, and also how they differ a little bit from our canine and feline cases, because most of the people listening to this podcast will be canine and feline centric practitioners. And I know that there are a few sort of differences within equine behaviour medicine. So what are some of those, Gemma?
Yeah, so originally I got the reputation for the vet that could deal with a lot of needle shy horses. So I dealt with a lot of and we still do deal with a lot of situational anxieties. And that caseload has changed. Lots of them I used to go out and they'd be needle shy, or they didn't like having their legs handled, or, and they would be like a 5-10 minute consult. And we could just use learning theory and we could retrain these horses, and the vets were happy and the owners were happy. But of course, we've trained the vets how to do all of these techniques and how to read equine behaviour a bit more now. So now if I get referred a needle shy horse, it is on the other end of the spectrum. Mm-hmm. It is that 1%, and they're the ones that have chronic pain. And we're often looking at all the other aspects of that. So the kind of, the horses that don't load, the horses that you can't clip, the needle shy ones, they were the kind of slightly more training based ones. And now we've really moved into the more intense equine behavioural medicine cases. So anxiety, human directed aggression. I think the ridden aspect is something that obviously we don't ride any of our companion animals.
Yeah.
And it's a real interesting area because people pay an awful lot of money to have a horse to ride. And it's very different to a pet. Now, a lot of people do increasingly keep horses as pets and will say, well, if I can't ride them, that's fine. I will keep them as a pet. But it can be as much as your mortgage to keep a horse. And so for a lot of people, they say, but I'm spending this money to be able to ride, and this is my outlet from work. And so that's a problem for me if I can't ride. Mm-hmm. So understanding how the horses feel about being ridden, again, it comes back to that musculoskeletal pain aspect of it. It takes up a huge component of my caseload. And we talk so much about the fact that lots of horses have pathology just the same as we as people have pathology, but actually some of them cope really well. And I always say I had a friend's horse that I think he was about 17, 18 when she retired him. He might even have been older, and he was lame, But every day she went to catch him from the field and he came, trotting up with his ears pricked. And he would look so happy when he was being tacked up. And then she'd take him out and he'd look a bit stiff. And I'd think, oh, he's looking a bit stiff walking up that track. At what point do I say something? But then he'd walk it off. And he was just so happy being out and about and hacking and seeing things until one day he wasn't that happy to go out. And that's when she retired him. And, and I see that similar. I know nothing about dog and cat behavioural medicine, but you see your kind of older dogs that are so excited to go for a walk and look a bit stiff, but then they ease it off a little bit. And you know that they're still getting some joy from that, even though there's some physical discomfort. So this is where we come back to owners and say, if we can have a horse happy, they will cope with low levels of pathology. But if horses are not happy, and a lot of this, it can be the ridden stuff, the behavioural interactions. But if you think about the 5 domains model, a lot of this is their nutrition and their environment and other aspects. And if we get those bits right, the horse can cope with a bit of bone spabbing or something like that and still be a happy ridden horse. And then the only other bit I'd say is probably the one that I think is massively different to dogs and cats is I don't believe you ever deal with sleep deprivation collapse. Because small animals lay down, and if they fall asleep, lay down, they fall asleep. Whereas horses, this is something that we're seeing increasingly.
Oh, wow.
Whereby, they're not choosing to lay down to sleep, and it's a really complex condition, and therefore they go into REM sleep standing up. And when you've got over half a ton, 600-700 kilos of animal that goes to sleep standing up, they hit the floor, and they're in REM sleep, so they're completely unconscious. They fall, they hit the floor, and they cause themselves some significant injuries. But some of these horses are collapsing. Oh gosh, it must be up to 30-40 times a night.
What?
So,
wow.
Yeah.
I did quite a bit of reading on that when I was studying for my boards, but obviously I think that's different again to actually seeing those cases. And I know you've started doing quite a bit of work with using overnight cameras and videos and that sort of thing. And I think that's been pretty game changing for you, if I'm not wrong.
Completely. And I guess that's another area that's very different to companion animals, in that people tend to live with their animals, and I notice with my dog, there are things that I notice on an evening that are different to during the middle of the day and things like that. Whereas people will often come up and they're with the horse for an hour and a half, maybe 2 hours maximum. They might put them out in the field in the morning, or they might live out, or, they might be there while they're mucking out. But they're, in terms of the amount of time that they're with the horse, not doing anything with it, is very, very limited. And there's some really nice research from the New Bolton Centre showing that when they video horses, they'll be showing evidence of discomfort. And as soon as someone walks onto the yard, they just go and they start eating their hair nets and like, yep, I'm fine here. Nothing to see. And then the people leave and they go back to showing evidence of discomfort again. Yeah. And I do quite a lot of overnight video analysis of horses now. And it always astounds me just how much discomfort I see in horses, and not always in the direction that I think I might be expecting to see it. It's a really valuable resource.
Yeah, that's so cool. I first heard about that from the New Bolton Centre, Sue McDonald talking about that and showing some of these behaviours, like you say. And that's where, horses as prey animals are, I guess, quite unique in that they don't show, vulnerabilities and signs of pain when people, i.e. predators, are around. So having that overnight video footage is just brilliant. And I'm so pleased that you found it equally as valuable, because I think it just makes so much sense to be able to see them. And like you say, in those periods of time where we as people aren't with them, I think that's such a cool thing.
Yeah.
Yeah. And so chat to me a little bit about psychopharmacology, because as you know, psychopharmacology is a massive passion area of interest of mine. And I know that we're using psychopharmacology more in horses. And again, I've probably got very limited practical experience. So what types of cases are you using psychopharmacology? And I know that we have to be a little bit more careful when it comes to competition horses and so on. So yeah, how would you say that that's fitting into your sort of daily practice?
I think it's just been a game changer. I just think it's one of those things, isn't it? When you learn about something and you think, how did I manage before? And you did manage before, but there were probably more cases euthanized. And I don't think we make the progress as quickly as we can do now. And I think from a safety point of view again. You know, for some of the horses that are really fearful of veterinary interactions, but we have to get them in for perhaps nucleus integraphy or something else, just being able to do that. And we do a lot of imaging, you know, so like I say, nucleus integraphy, but then getting radiographs and CTs and everything afterwards. Of course, we don't anaesthetize horses for these things, so we can keep our images safe by keeping the horses more relaxed. But the first case I ever used any medication on was actually a 2-year-old racehorse in Newmarket. And I was asked to go see it from the insurance company because it was extremely aggressive. And they said the main problem is catching it in the stable. They said once you've caught it, you can do most things with it. And you have to have a degree of respect for the horsemanship skills, not necessarily, you know, I mean, this mare came to them with lots of problems. She went through the sales rings at Tattersalls, and after she was purchased, someone came up to them and said, you need to be really careful in the stable with this mare because someone's going to get really badly hurt by her. So that was known before she was purchased, but I couldn't believe they'd even been able to back her and get things done with her. And anyone that went near her box, and they had tried, you know, again, the racing industry often gets a bit of a bad rep, but actually they tried it in so many different stables, and they tried different setups, and they tried this and that. And they got to the stage where they, you know, she'd picked people up with her mouth. And there was concern that she would come down and she would rear and strike, and she'd struck people kind of in the chest. She hadn't had a head injury yet, but it was going to come. So I went out to see her, and I actually said, because there was going to be a time delay before I could get down, I said, let's start her on some gabapentin. And then I spoke to the trainer and I said, look, I'm coming down tomorrow. Has it made any difference? And he said, maybe 10%, maybe at a push 20%. She's just that little bit not quite on edge, but she's still incredibly aggressive to people. And I went down. It was actually the day after Boxing Day, because I thought, oh, this mare's going to kill someone. Like, I really have to get in there. And I didn't have any other time gaps. So I drove down and we did some work with her. And we retrained her to put her nose in a head collar over the door using positive reinforcement. And she was great for that. It just changed how she was for that. But the other bits, they were kind of slowly starting to work out. And then they were reducing the gabapentin, and some things were starting to sneak back in again. And then from that, someone went into a stable just quickly one day to tack her up, and she reared up and struck them again. And he said straight away, it was my fault. He said, you know, we don't rush into this mare, but I was late. Everyone else was ready to ride out. And we did have a conversation that she was still a significant risk. And, you know, getting her, as we were weaning her off the gabapentin, she was brilliant to catch. You know, that never deteriorated, but the other bits were a problem. So sadly, she was euthanized. But it kind of opened my mind up that there are other things. And I've had very mixed results with gabapentin from an anxiolytic point of view. The next medication I started using was fluoxetine. And that was a horse that had been attacked by dogs. And then the physical injuries had healed. But this horse was just so stressed and anxious about everything in life. And, you know, his owner was in her late 70s. And again, they were going to euthanize him because she said, I can't even bring him in from the field anymore because he's going to knock me over. And that was another one of those light bulb moments. And they tried doing, you know, the vet knew a little bit. They tried doing some clicker training, and they said, well, when we do that, he's fine, but he's still generally anxious. And that horse just transformed and became safe again. And then trazodone, vitamin T.
Yep.
What a game changer. You know, in terms of these situational anxieties, and in terms of getting something that works really quickly. Because I had another stallion that I put on fluoxetine that was a sports horse stallion. And, you know, it takes a long, long time. For him, it took a real long time to really have a big effect on him. So to have something that we can just go, right, we need to get on top of this now, was great. And then in terms of other meds that I use, alprazolam can be really useful for the situational anxieties. I think something to really think about in horses is the fact that it can cause some weakness or ataxia. So people cannot ride horses on alprazolam, and I wouldn't want a farrier underneath a 17-hand horse, you know, just in case there is a little bit of a wobble anywhere. On the other hand, small pony with lots of musculoskeletal pain, you get that muscle relaxation. The farrier isn't under it anyway. It can be a fabulous drug. And then things like amitriptyline, for the chronic pain cases.
Mhm.
So we're still a little bit more limited. We don't have the range that you guys would have in small animal medicine. And I will only start using a drug once there's some publication somewhere that someone has used it in a horse successfully. Obviously, we have the cascade in the UK, so we need to be aware of that. And that's not to say that we couldn't consider using another drug, but I'm probably not that brave myself to use it for the first time.
Yeah.
And then, as you say, competition regulations. And the good news is I put in the paperwork for fluoxetine and trazodone to be moved from a banned substance to a controlled substance under the FEI regulations, and that's been accepted.
Yay.
So from the 1st of January 2026, they can be used out of competition. But I would say it's even something you guys need to consider from small animal behavioural medicine. If you're giving it to an animal that's on a yard with horses,
that's a good point.
Where does that dog urinate? Is there any possibility that the horse may, if they do urinate kind of on the side of the hay bale or things like that, there's any possibility that the horse gets any of that medication into its system? That can cause problems. So think about that.
That's actually a good point, because I'm aware of it for things like steroids, corticosteroids and that sort of thing. If you've got dogs on steroids and they're yard dogs, we always know to warn about that. But that's such a great point. Actually, I hadn't even considered that. When we've got dogs on psychopharm, we should always ask if they're going to be near horses and that sort of thing. So the
FEI had the No PP campaign.
No, what's that?
A large proportion of positive tests. People then said, well, actually, there's a male human, I should point out. Oh no, I think they've all been male. I'll be careful of going down that route. But a human that was on that medication that went to the toilet and that had a pee in the stable, rather than go around to the toilet because it was quicker. I think we'd say boys pee more places than girls generally. So they had a campaign to say, look, we're getting lots of positive tests. Now, whether that's entirely true or not is another conversation.
Yep.
But they were really pushing to say you cannot urinate in horses' stables, and yet how many dogs would go in and have a pee? That's
it. Exactly. That you're not really in control of, and you wouldn't have that dog under supervision the entire time. So that's a great point. Yeah, definitely want to think about, actually, for everyone listening that is treating dogs with psychopharmacology and other meds as well. Yeah. Cool. So let's chat a little bit about your PhD then, because I think that's such an incredible piece of work. And I know that you've also done quite a bit about the Don't Break Your Vet campaign. So a lot of to do around safety for vets, and I guess owners as well, right? When they're handling their own horses in those situations. So talk to me a little bit about, like, how did your PhD come about? Did you come up with a topic, or was it something that was like a group decision that this would be a great topic to kind of do some research on?
So it actually came about as a consequence of my residency and my master's. And when I was talking about topics for my master's, I said, it'd be lovely to have like a gold standard to determine is something pain or behaviour. And obviously now I know that's the wrong question to ask, and I was never going to achieve that in a master's thesis. But and we said that might be a bit ambitious for a master's. So we said, well, what about injury rates in vets? And I said, well, I think there might be, we should look at injury rates and also how much vets understand about learning theory. And so we showed that, well, first of all, we showed that vets understand really poorly about learning theory, even though they think they understand it really, really well. And the injury rates were really significant. So, you're looking at over 80% of vets which are injured in the last 5 years by a horse that they were working with.
Wow.
And so we kind of went, okay, that's fine. And then we had an intervention where we said, if we teach students about learning theory and a little bit about, monitoring signs of arousal and stress and things like that, does it change their perceptions? And we showed that it did. And also that they could then go on and in the kind of the delayed post-test, even when they'd spent time in the equine hospital, they were saying that they were using some of these techniques and it was safer for them. So then I thought, well, okay, I've seen it from the vet's perspective. We know that there's a need there. We know there's these injury rates. But what about the horse's perspective? And one thing I'm always saying to vets is, you know, when you get injured by a horse, these are normal responses to an acute stressor for that species. So if we can reduce the level of stress they perceive, you are less likely to get injured. And then I realized that there really wasn't a lot of research on that. So I thought, well, I need to do that research myself. So I came up with a research proposal, and then Professor Natalie Warren actually turned it into something that someone might fund, because my typical Yorkshire, I think we should do this, you know, wasn't that eloquent. And yeah, we got funding for it. So I went straight from a residency into my PhD. And again, I'd spent, you know, the last 4 years in the equine hospital at Edinburgh, and I'm always observing my cases and I'm always thinking about things. But actually to do a PhD, which meant that I took a step back and all I did was watch the horses. And, you know, I was filming them. We had heart rate monitors on. We were looking at salivary cortisol. We looked at surface eye temperature. But rather than thinking, what am I going to do with this colic? What am I going to do with this lameness? What about, you know, what's my next case? I was literally just watching the horses the whole time. And the amount I learned from that. And obviously there's kind of some of the results of it. And that's where it's actually before my PhD. So if I just go back. So when I was doing my research into injuries in vets, BEVA were doing a similar thing. And I think when they first started, they hoped that they could say, we should sedate horses more and that will keep vets safer. And that is a really important thing. You know, traditionally, a lot of owners didn't want to pay for sedation and would expect vets to do things that were not very fair, really. But they also found how many vets were injured by needle shy horses. So they thought, well, we can't just say sedation because that involves injecting a horse. Yeah. So that's where I went down and did the Don't Break Your Vet campaign. And they were just really short videos of real cases in a you know, a very normal riding establishment that we could show very rapidly that we could make a change. And then from that, I went on to do my PhD. And so we've looked at lots of areas that horses find stressful and how we, you know, the behavioural outputs of that. And then one of the last chapters was one of my favourite ones, which was classical counter conditioning for nerve blocking. And we showed that if you alter how you interact with the horse during the skin preparation phase, they then are less stressed during the nerve block. And furthermore, the more nerve blocks they have, the less stress they are, which is the exact opposite to what we normally see in these cases. And then from that, I had a conversation with BEVA about where do we take this next? And there were also a few conversations going on in different areas. And we kind of said, well, why don't we come up with a course? You know, the Don't Break Your Vet videos are fine. There's like, I don't know, 5, 7 2-minute videos. But people were asking for more information. And we thought we'd come up with an online course, which we called Hold Your Horses. And it's 4.5 hours worth of lectures, but they're all split into 20 to 30-minute lectures. And again, it's really based around cases. And it's kind of moving people away from a very basic understanding of learning theory, which can be a little bit mechanical, to understanding some more of the nuances and equine behaviour. And I can't remember, I should have looked up the figures, but I know we've had over 100 people, over 100 vets complete that course so far. And they're continuing to do so. So it's free for BEVA members. And yeah, there's people internationally actually that are using that. So again, it's just really nice to see that changing attitude from vets, from whereby they used to be very much, oh, the horse has been naughty, we have to restrain him. Whereas now they're saying, okay, we need to help this horse, we need to do something different.
Yeah. And is that course, so you said it's for vets and obviously free for BEVA members, is that also suitable for veterinary nurses that are working with horses?
Yeah, my fault. It's suitable for vets and nurses. And we've had grooms that have done it as well. A little bit on the psychopharmacology. The grooms can, I think they could still enjoy watching it because it's case-based, but we wouldn't expect them to understand what's going on at the level of the neurotransmitters. But yeah, it is for vets and nurses.
Brilliant. So I will make sure that I get the link to that and I'll put that in the show notes. So anybody listening who's interested in that course, you can find it directly beneath the podcast episode. And then the Don't Break Your Vet videos, they're just available on YouTube, right? So if somebody puts in YouTube Don't Break Your Vet, they'll find the videos there.
Yeah, exactly that.
Perfect. Sounds good. So finally, if you're up for it, I wanted to dive into this whole question mark around how do we start talking about pain, not versus behavior, but pain and behavior, pain, like in terms of, you said earlier, that's the wrong question, right? Is it pain or behavior is the wrong question? We know that also from a small animal point of view now. But how would you say, also from an equine point of view, what's the best approach? Like, how should we be looking at these cases where we're suspecting that there might be pain, but we're also seeing that there are behavioral challenges? What's your approach?
So when I talk about this, and I gave a plenary at the ICES conference, the International Society for Recreational Science conference on this, and I always start off challenging people and say, what is behavior? And then they go, oh, because they think they know what behavior is until I say, what is behavior?
Yeah.
And then fundamentally, behavior is the motor output of sensory input.
Yeah.
So if a horse presents as lame, that is a behavior. The horse has altered their motor output to bear less weight on a limb because the sensory input is that there's pain there. If a horse is colicking, this is a collection of behaviors that we associate with abdominal pain. So I'm really pushing back to the vets and saying, when a horse presents with aggression or anxiety, that's the motor output. I mean, anxiety is probably not a motor output, but you know what I mean.
Mm.
What is the sensory input that's driving that? And then if we talk about, what is pain? Pain has an emotional component, and pain is in the brain. Nociception occurs elsewhere in the body. That provides feedback to the brain, but fundamentally it's the brain. The brain is the only organ that perceives pain and thinks about how you're going to react to it. So the way I would approach these cases now, and obviously I've looked a lot at what evidence do we have for cognitive, emotional, and physical areas. But another thing that I'm working through now with owners when I'm taking a history on these cases and examining the cases is going back to this 5 domains model. And the 5 domains of animal welfare was updated in 2020. And that was an equine thing. I know Dr. Andrew McLean was involved in having this conversation with Dr. Mellor and Professor Mellor, and saying, you talk about interactions, but we don't really talk about the horse-human interactions. So, I look at nutrition and I'll go, how is this horse's nutrition impacting its mental state, which is welfare? And is it having a negative impact? And we're seeing this increasingly with horses that are on restricted diets. Or is it having a positive impact? And then what about the environment? What about the physical health, which is a whole world of complexity? And then what about the horse's interactions with other horses, with the environment, and those horse-human interactions? And I kind of go around the 4 domains, and for each of them ask, how is this impacting the 5th domain, mental state? And then you start to build up lots of evidence for one area over another, or for there's 2 areas which are mainly competing, and really try and use that as a way forward. And then your treatment plan revolves around that. And of course, the 5th domain, mental state, is where your psychopharmaceuticals come in, where you go, actually, we're changing these other bits, but we need to have a direct impact on how that animal feels.
Yeah, no, I love that. And I've spoken a lot recently about, because I think we in the small animal world were doing the same for quite a long time. Is it behavior or is it pain, or physical health in general? And should we be targeting the physical health before we do anything about the behavioral health? And no, it's not that. We should be looking at things at the same time. They're not isolated occurrences. And if you have an emotional component of physical pain, you probably need to treat that emotional component as well as, whatever it is that's causing that pain. So I think we are getting there slowly but surely. But I think we got so excited a few years ago when we realized just how much of an impact pain and physical health are having on behavior, that we forgot to integrate the 2. And I think we're kind of coming back to that again now.
Yeah, and it's interesting, you're talking about the animal's emotional health. I've also got some nice research ongoing with Dr. Tamsin Furtado understanding human perceptions of having a horse with problematic behaviours. And this can be, you know, really simple, or it can be the really complex cases. But there are kind of a few areas which we've seen which they need to have to have. The more they have good success in each of these three areas, the more likely they are to have success with a case. And one of them is that the owner understands, so sense making, what's going on. One is that they believe that there's a potential solution. And that's where I think it's really important to get some success quickly with these cases. So treating the emotional aspect of pain at the same time. Who cares what percentage is physical versus mental? Let's just get the animal happy again. And then you've got the owners on board, and then we can start to, you know, take some layers away and see where we're at. And the last one is the emotional capacity of the owners. And I've had owners that, you know, and I'm sure it's the same in small animals as well, but they've bought several new saddles, often at several £1,000s each. They've been to lots of different trainers. They've been to different physios and chiropractors, and they've maybe been to the vets a couple of times, and they've tried every supplement under the world. And by the time they come to you, these owners are just emotionally exhausted. And trying to deal with a horse with problematic behaviours is having a really negative impact on all other aspects of their life, their work, their, you know, their interactions with their family members. So again, just getting on top of something quickly gives them that time to breathe before we then start to delve into some of the more nuances. And often you don't have to do.
Yeah, I completely agree with you. I always call it like getting some quick wins, you know, and trying to identify where can we get those quick wins. Because you're right, you know, by the time, a lot of time, small animal, equine, whatever, by the time these clients, owners get to you, they are done. They're financially done. They're emotionally done. They haven't got, you know, their time poor oftentimes. And so being able to just kind of be that little light at the end of the tunnel to show them that, yeah, whilst we might not be solving the problem in its entirety, you know, we can perhaps get some of these quick wins. And I actually love that you look at the you know, the client side of things. I've heard you present on that in a few of the European college conferences over the last years of what actually is the caregiver burden and the owner effect and all that sort of thing. Because if we can't make inroads into that, it's through the owner that we end up being able to get to the animal. So we have to have that kind of that path to helping the client as well, as much as we can, and as much as is within our remit in that moment.
Yeah, of course.
Yeah. Amazing. Is there anything else you'd like to add? Is there anything we haven't touched on? Is there anything burning that you need to get off your chest before we wrap things up?
No, I don't think so. I think that's covered most of kind of what we do and where we're at. And I think equine, as is the case, because there are fewer horses than there are dogs and cats, at least in the UK. But I think we are a little bit behind where small animal behavioural medicine is. But increasingly, vets are getting on board with this, and it's being recognised as its own discipline. And I feel like everything now is just slowly moving in the right direction. So this is where we need more equine vets to come into equine behavioural medicine. And you know, we've had this conversation before about you really do need to be a really good equine vet primarily, and then come in and add the behavioural medicine aspects on because of the nuances of all the physical aspects of it. But that is increasingly happening. So yeah, I think it's all going in the right direction.
I think so too. And I think you're a huge reason for that. It's actually funny. So I think I mentioned to you when I had my new boy, Joey, when I had him vetted, I had a vet called Chris Tufnell who vetted him. And I met Chris when I went back to the UK, and he came and just kind of checked Sky over my older boy and did a couple of checks on Joey. Joe needed his teeth doing. And we spoke about you, you know, he sort of asked what my interest was, and your name came up. And I think, you know, and he said, oh yeah, I think you guys know each other through the FRCVS, maybe, I'm not sure. But I think you're right. It is, you know, vets out there working in general practice, and Chris is an extremely experienced vet, and you know, it is amazing. But I think you're right that behavior medicine is being recognized more and more for the importance of it, you know, not just that it's there and it's kind of a nice to have, but actually quite how important it is. So I definitely think the word's getting out there, and I think you're doing just such an incredible job at pushing this field forward. And yeah, I'm hugely inspired by the career path that you've managed to carve out for yourself and all the amazing work that you're doing. So yeah, it's amazing.
Thank you.
Yeah, my pleasure. And thank you so much for your time today, for sharing all your amazing wisdom and also a little bit of an insight into how you got to where you are. So thank you for your time. I think this is going to be such a popular episode. We will get definitely the link up in the show notes for the Hold Your Horses course, and I'll see if I can find the YouTube link for the Don't Break Your Vet video series. And where can people find you if they want your help? Where can people find you?
So if they want to, they can find me through the University of Edinburgh. It's probably the easiest way for that. Obviously, we have a link for referral of cases, and I'm always really happy, you know, if vets want to work with me on a case. I think slightly different to the other aspects. I'll often do a history with the primary vet present because they want to learn about this area. They want to understand it. So we can provide ongoing support. But I do, obviously, everything is done through veterinary referral. So if there are owners, I won't speak to them directly unless I've got a referral letter from the vet.
Yeah. So if any horse owners listening, get in touch with your GP vet and get them to make a referral through the University of Edinburgh. And if you're a vet that's listening that wants to have a chat to Gemma or has a case, then yeah, you can go through the same pathways, I presume.
Yeah, and the vets, it doesn't have to be a referral. I have lots of vets that just want to have a chat about cases, and particularly psychopharmacology or an approach to things. That's fine to just have a chat with them.
Fantastic. All right. Thank you everyone for tuning in. Thank you, Gemma. Thank you for your time and for chatting with me today. And I will see you all next week for episode 114. Bye for now.
Thanks. Bye.